His co-pilot, Dr. Nicole Higgins, may also be with us shortly. Had a few little technical hitches in the background there, but we hope to have Nicole online soon. So I'd like to start tonight by acknowledging the traditional owners of the land in which this meeting is taking place and pay respects to their elders, past and present, and their families. So just a little bit of webinar housekeeping before we get started. So everybody's microphones are actually muted so that we don't have any background noise during the presentation. I'll also mute mine while Bruce is presenting, and then may jump online to ask some questions that I can see you all putting into the chat box. So any questions you've got throughout the presentation, please pop them in the chat box and we'll try to get to them as we go through the presentation tonight. Also, we're recording this webinar, so for anybody who has registered and isn't able to be with us tonight, they'll be able to go to GPSA's YouTube channel and watch the webinar later. So without further ado, I'm going to hand you over to Dr. Bruce Willett to introduce himself.
G'day everyone. Thanks for holding on through those technical problems. I'm sorry about that. And we'll try and have everyone finished in time to watch the super blood moon eclipse tonight, which I think will be really worthwhile. Just a little introduction of who I am. I'm Bruce. I'm a supervisor of about 30 odd years. I've been with GPTQ. I'm the immediate past president of GPSA, and I've worked just in the south of Brisbane for the last 30 odd years as a GP and as a supervisor for a good deal of that time. And I'm the SLO for GPTQ as well. Yeah, for those who are having some sound issues, apparently it's pretty common to have them early on as everyone's joining up. And for most people, they should settle down. So if you can just bear with us for a little while, I'm sure those will improve. So thanks everyone for tuning in tonight. So they're the objectives. I won't read them all out, but really tonight is about sort of early skills for supervision for those who have not had much experience. So just to cover a broad range of topics of a supervision without going into a lot of depth of them, and just hopefully a few little tips. For those of you with lots of experience, I'm sorry, I'll try not to bore you, and try and keep it pretty relevant to, and if I can. So I have been a medical educator, but mostly I've been a GP in my life and I've been a supervisor. So for me, this is all about the practicality rather than the theory. It's about what works, what you're actually going to do in your room and around your rooms with your registrars. So we might start off with a poll just to get an idea of how much experience people have in supervision, and that might give me a little bit of a guide as to where to pitch this. So I can see everyone's voting. Thank you very much. So one of the things I'll do, and I'll ask Nicole and Shelley to do, if you've got any questions as things come up, just type them in the box down below, and we'll try to answer them. I would like to make this format as interactive as we possibly can. It's difficult to be very interactive. So it would be great if you can make some suggestions as we go on and ask some questions. And Shelley and Nicole, or Nivcole, will post those as we're going. One of the things is that one of the things we do with these webinars is that we post them onto YouTube for people to watch back later. one of the things I've found when I'm watching them back is that the questions that are asked don't come up on YouTube. So often when the presenter's answering them, you don't actually know what they're answering. So we'll be trying to read back your questions before I answer them. So the other thing that doesn't come up are these polls. So just for everyone's benefit on YouTube, 28% of people said that it's their first year, 33, 1 to 3 years, 4 to 10, a quarter, and more than 10 years, 12%. And I don't know why I'm not giving this talk. Only one person said that. And it wasn't me. So there's quite a broad range of experience there, quite a few people in that 1 to 3 year mark. So, to begin the talk, before the experience of the registrar actually starts before they start work in your practice. So I'd like to talk a little bit about practice culture and setting things up. So registrars come with a wide range of experience now. Some of them have been through other training programs and have lots of experience in other specialties. Some of them are actually coming straight from their 2 years in the hospital, and it certainly changes the experience and changes the expectations that we will have of the registrars. I've been a supervisor, as I said, for quite a few decades now, and one of the things I'm noticing is that residents are getting much better supervision in the hospital than they did when I was a resident. But of course, the downside of that is that that it also means that a lot of registrars are coming into our practice not having made a lot of decisions before. So a lot of them just need a lot of confidence, a lot of them need a lot of support around having to make clinical decisions by themselves, one-on-one with a patient. And that's certainly something that's changing. But on the other hand, there are people who have been orthopedic and surgical registrars and medical registrars and have had quite a lot of responsibility. So one of the first things I'd urge you to do is to sort of get to know the registrar right from the beginning when you're interviewing registrars and trying to decide which registrars that you'll be taking. So the next thing that I think is really important is that you don't have to be perfect and you don't have to have all the answers. So it's getting to the glib expression that's often used is that the supervisor is the guide on the side, not the sage on the stage. So a lot of your registrars will come to you with lots of experience and they'll know a lot more about some areas of medicine than I certainly do. And so one of the things I do in setting up the experience with registrars is to tell them that I expect to learn something from every registrar that comes into my practice. To create the expectation that you expect them to be teaching you as much as you teaching them. The other thing I often say is that my job is not to teach them medicine and not to teach them all about general practice, but a big part of what my job is to actually to help them adapt what they already know to a general practice setting. So I tell them that they already know 95% of what they need to know, and that my job is to help them apply that knowledge in a general practice world. It's probably not exactly true. There's probably a lot more that they need to know, but I think it's a good place to start. So a lot of it is about culture. One of a CEO that I know who has a lot of experience in running quite a few companies once told me that his job as a CEO is actually really simple. People think it's complicated and difficult, but it's actually really simple. So there's two parts of it. The first part is just remember what it is that you're trying to do and you're trying to achieve. And the second part is don't do anything that's stupid. And I think those two rules apply really well to supervision and basically anything you're doing in practice. So just trying to avoid doing stupid things keeps you out of a lot of trouble. So the introduction. So as I said, the introduction begins in the interview. So it's important that you explain to the registrar, the potential registrar that's coming to your practice, what the expectations are in your practice. So what hours they'll be expected to work, what the billing's likely to be, the way the bookings work, what form the teaching takes and where it will occur, what the pay will be, and what the support will be, who they can turn to and how during their term. It's really important that they know that before they accept the job, and it's really important that those things are all sorted out. It's important that they feel safe and secure and supported in your practice. The other side of the coin is preparing your staff for the registrar. So registrars will come into your practice on a fairly regular basis. So once the practice gets used to having registrars, it tends to be a fairly smooth process, but most practices find when they first start taking registrars that it can be a little bit difficult for the receptionist to understand exactly what a registrar is and what the different requirements are for registrars. So it's really important that you have a staff meeting and you brief all the staff about exactly what a registrar is and what their requirements are. I found when I first started having registrars in my practice that the receptionist would see the time that was blanked off for teaching, and there was people who were wanting to get in that day, and they would automatically just start to go like, oh, well, that's not important. That patient, getting in is really important, and they'll just squeeze it in, squeeze the patient in. And so gradually the teaching would get eroded. So it's really important that all your staff are briefed that the teaching time is booked and it's just the same as if any other patient was in there. You need to talk to your staff about how they're going to explain what a registrar is. Patients will often struggle to understand the term registrar. Of course, it doesn't really mean anything to them, and often the risk is that patients will interpret that as being a student doctor. So you need to equip your staff with some words to explain to patients. So in our practice, I'll say that these are fully qualified doctors undertaking extra training into the specialty of general practice. I found that it's important that patients know that they're registrars, because if they think they're just any other doctor and then they move on every 6 months, then the patients get a bit grumpy. I think they're entitled to know that they are a registrar and that they are undergoing some sort of training. But it is important that the staff are equipped with the words to explain that. The next thing is before the registrar turns up on day one, it's really important to have contracts signed and sealed and completely fixed up. As I said, I've been a supervisor for the best part of 30 years. I'm not quite sure how long. In all of that time, there was one occasion when I didn't get the registrar to actually sign the contract before they started work, and that registrar turned up on day one and said that they'd been talking to the other registrars and actually I wasn't paying them enough. This is while the patients are in the waiting room, and that I needed to increase her pay and change her hours, and it was a really unpleasant experience, and it gets the teaching off to a really bad start. So I can't emphasize enough that it's really important to have those contracts signed weeks, months, well in advance of the registrars starting the term. I know it seems like a no-brainer, and that I'm emphasizing something that's really simple, But over and over again as the SLO, I have experiences with practices who don't do that and it all turning bad and ugly and the term never really recovering. So very simple, but please do it. Then the next thing is think about how you're going to look after yourself during the term. So particularly for the first term registrar, the GPT-1 registrars, they're going to have to be calling you fairly frequently. So yes, so Nicole said to make sure, we'll get to that. Yes, make sure they have indemnity and registration and all those things. So looking after yourself. For GPT-1 registrars, they're going to be calling you quite frequently. As part of setting up the expectations with the registrars, I will say to them, I'll actually talk to them about a friend of mine who used to like to do a lot of palliative care, and he actually found it very rewarding and very interesting. But he said to me, Bruce, I really like doing palliative care, but you know, one of the things that I really like to see in my patients is progress. I like to see them progressing. And I find that that's very similar with registrars. So and I explain that to the registrars. So if in day one they sit in their room, they see the patients, and I get no calls, I explain to them that I'm going to be fretting. But on the other hand, in the last day of term, if they're still calling me about every patient, that's also inappropriate, and that's also a worry. So in the beginning of the terms, particularly the first term of the year, when it's in the summer, it tends to be a bit quieter. There's more GPT-1s. Consider putting in a few blanks or banning fit-ins with yourself so you don't get frustrated and frazzled and angry and uptight. And you can greet the registrar with a lovely smile when they ring you. So checklists are really useful. So because registrars come and go fairly regularly, the whole experience of registrars is actually really enhanced by setting up some systems around your teaching and the way you handle them. So this is an extract from my practice manager's checklist for the registrars of things that will be done before the registrars actually even walk into the place. So she will work through this. There's a few more things on it to make sure that everything's done. For those who are having trouble hearing, Marissa will be helping work those out. So if you can just bear with us. So the next thing, orientation day, the first tie their hip. So orientation is now a standard from the RACGP. Well, it's been a standard for some time from the RACGP and ACRM standards in practice training. Again, I find that checklists are really valuable. So things that you need to go through with the registrars, because as they come and go, you often find that I will forget things or think I've said something to one registrar and I've actually said it to another, and those sorts of things. The other thing, we have short lists rather than lists of common referrals. So the book in the address book in the software tends these days to fill up with lots and lots of names that are just overwhelming for registrars. So we have a list of common people that the registrars may like to be referring to. And some of those names I'll actually put a little asterisk beside it, which is just to indicate you may want to refer to this person, but there's actually something special about this specialist that I'm not really wanting to put down in writing, and you might want to talk to me about this specialist as well. Giving the registrars a copy of the practice policy manual is a good idea, and having some written explanations of billings and things is also helpful. A practice information sheet for the registrars is useful so that they know a little bit about where the practice has come from and how it works and those sorts of things as well. So this is an excerpt from my checklist that I work through. There's 2 columns. So stage 1's are things that I try and get through in the first day. and stage 2 are things that I will try and get through in the first week or two. And some of them are actually for the practice manager to go through, some of them for the nurses to go through, and some of them for the reception staff to go through. In terms of resources, GPSA have tips and tricks for new registrars manual available free for download on the GPSA website. And that actually has in the back of that, it has a checklist like this. So what I'd urge you to do is, for those of you who haven't already done it, is to actually sort of copy and paste that into, it actually works well in Excel, and then customize it as you use it over the years. So in terms of what actually occurs in the practice, there's really two roles for a supervisor. So the first role is actually the teaching role, the one-on-one teaching, and the other is the more strict supervision role, making sure that the registrar stays safe in the room and keeping an eye on your registrars. So in terms of the teaching role, I would urge you to actually think fairly broadly about what you do and how you do it. The latest RACGP standards for in-practice teaching have recognised what's long been the case, and that's that teaching tends to occur in the practice rather than just with a supervisor. So the new standards are framed entirely in terms of the practice. And the role of the supervisor, there's a notion of something called a supervising supervisor or a lead supervisor, whose responsibility it is to make sure that all the teaching and supervision occurs, but it's not their responsibility to actually have to do it all themselves. So think broadly about who does the teaching. So often it will be the practice nurse, it might be the practice manager explaining about billing. It might be the receptionist talking about how they book people in and explaining about how they deal with difficult patients and problems at the front desk. Some practices I think very broadly about this, and I'd encourage you to do that. I know of practices that take the registrars to the local police station. So they're in a small country town. They have quite a bit of interaction with the police and the fire department. And so they actually take the registrars around to meet the local policemen and the firemen and explain what the firemen will be doing and what happens in emergencies. And that's actually part of teaching. The important thing with that is, of course, is that you flag it with the registrars that it is teaching. I actually also organise sessions with the local physiotherapist, with the local optometrist, and with the psychologist that works in our practice. And they talk about things of common presentations that come to them from general practice, things that they perhaps think could be referred a little bit earlier or a bit differently, and they give a wonderful background of a different aspect of general practice that the registrars aren't going to get anywhere else. And importantly, it's all work you don't have to do. There is some work involved in setting it up. You need to talk to the registrar about what they need, and you need to talk to the allied health professional about that, and you need to set some expectations with the allied health professional about what you expect that they will be doing. And then you need to talk to the registrars afterwards and find out what worked and what didn't work and feed that back to the allied health professional and find out what worked and what didn't work and feed that back to the allied health professional. So there is a little bit of extra work setting it up in the beginning, but once it's running, once the alternative teacher has been doing a few of these sessions, you find that it actually runs pretty smoothly and actually saves you a lot of work in the long run. It is recognised as teaching. It's up to you whether you pocket the teaching allowance for that time or pass that on to the other person. In general, I always offer to pass it on, but often often they refuse it because they're happy to do it because they get the referrals, and a lot of people don't offer it for that reason as well. Yep, there's other suggestions. Yep, driving around the suburb is really useful. And yes, I actually have also asked registrars to do some sessions in the pharmacy, going through a lot of the over-the-counter stuff that they won't have counted very much in terms of their previous hospital experience. So, so we've already discussed most of this. So in the beginning, when you're setting up the teaching, you need to talk to the registrars about how it's going to occur, where it's going to occur, and when it's going to occur. So I personally like to do a lot of the formal teaching outside of the practice. There's a coffee shop around the corner, and there's a table in that coffee shop that's outside and around the corner from the rest of it, where I can have some privacy. So it's good for both myself and the registrar to clear our heads and get out of the practice, and I buy the registrar a cup of coffee. Has the added advantage in that we don't get interrupted by telephones, and can you just do a script and so just wants to ask a quick question. So it's uninterrupted times, and I find it's good for both myself and the registrar's mental health. It's really important to spend some time to get to know your registrar, their circumstances, and to get to know them as a person. So one of the important roles as a supervisor is to be to provide pastoral care and to be a mentor. And as part of that, it's really important to know who your registrar is and what's going on in their life and the background. So I actually will spend a couple of teachings, well, at least one teaching session early in the term, just chit-chatting about stuff around medicine and around the registrar's wife. It's important to signpost that this is a teaching session, and because probably the second most common complaint from registrars is that they don't get their teaching. The most common complaint from registrars is that they don't get paid enough, and they're unhappy with their paying conditions. But the second most one is that they're not getting enough teaching. So it's often really important to explain that some of the things that you're doing that may not seem strictly to them teaching is actually still part of teaching. The other thing I do early in the term is to give registrars a self-assessment tool. So there's some available on the RTP's website, and most of them have them where they can go through and tick and flick things about how confident they are in some areas. I also keep, as I do teaching sessions with registrars, I actually just jot them down again in an Excel spreadsheet about what I've talked about. And over the years, I've just built up a list of topics that I've noted that registrars like to talk about. And I print that out to registrars and give them to them in the beginning of the term and say, look, this isn't the curriculum. We don't have to cover everything on there, and we can talk about things that aren't on there. But you know, it's a great place to start a teaching session from. As you know, is there something in here that you'd like to cover? So getting back to the resources, I've already talked a little bit about the in-practice teaching guides that you can download, the one that's tips for new supervisors. But also on the GPSA website, there's a whole lot of teaching plans available freely for download. So I'm very passionate about these because I champion them. The idea of them is that you can go to the GPSA website, download the teaching plan. It has a rough in point form things that you might like to cover. It has some links to some websites for some resources where you can brush up on things before you actually start teaching it to the registrar. And then there's some questions that are very roughly based on the 3 parts of the RACGP exam, so the AKTs, the KFPs, and the OSCEs. So I find that's fabulous. So often you get to the morning where you've got the teaching session and you realise that you've done nothing in preparation, and you haven't organised anything. It's really great just to give a quick phone call to the registrar, say what do they want to talk about, go to this, download it, and then start the session from there. Often you can ask them to pick one of the topics from your list of preferred topics. So that's available freely from the website. You just need to register and join GPSA as a member, and that's free. So in terms of in-practice teaching, there's a couple of ways of doing it. Many of you will have heard of the wave teaching model, which is where the registrar is seeing a patient in one room and you're seeing patients in the other, and you walk in and see the patient after the registrar has done it. It's rare that you'll need to be doing that with the registrar, but again, the new standards say that each registrar should be assessed for the level of supervision that is required before they come to your practice, and that should be done by the RTO, as it now is. And there should be some recommendations around that if a registrar is likely to need extra supervision. So this is mostly for medical students, but there are some registrars who are likely to be coming to you who may need this sort of closer level of supervision. The next one is direct observation of teaching and consulting skills. So this is, I think, essential, and again, supervisors are required to do this, and it's really important to do it early in the term. So we all should be doing this in this first week or two of the new term. Unless you sit in and watch the registrar and see what they're doing, there is absolutely no way to know whether or not they're safe with patients. So it is, I think, mandatory to do this, to actually organise some time to sit in and watch them. The other thing that I do as part of orientation is I will actually get them to sit in and watch me. And what I get them to do when they're doing that is that they sit and work the computer. So they get to see how I consult, and they get to learn how to use the computer software at the same time. So that's a really useful thing with the registrar watching me and using the computer, but you still need to, early in the term, spend some time with the registrars, watching them and seeing what they're doing, and providing some feedback on their performance. Another tool that you may have heard about is random case analysis, and there's the son of random case analysis, so it is inbox analysis, and the son of that is pathology analysis. So there's actually some previous, there's actually a whole previous webinar about this topic, and if you're interested in it, it's worth going to the YouTube channel and having a look at that. And I think there's a link in there, or I'll ask Shelley to put that up. What it involves is going through the registrar's patients of that day, opening their notes up and asking the registrars about what they've done with that patient. So what happened with this patient? How did they present? The next thing is, though, is to move on to talking about, you know, what they were thinking and why they thought that, and probing a little bit more deeply into what they've done. It's really important because it's getting to the clinical reasoning stuff. So this is all about teaching clinical reasoning. Registrars traditionally have been very unenthusiastic about teaching about clinical reasoning because they just want you to tell them how to treat diabetes. They don't really want to talk about airy-fairy stuff like clinical reasoning. That started to change over the last couple of years, and that's because of a thing called the KFP and the failure rate of the KFP. So because the KFP is very much designed to be a exam about clinical reasoning. Registrars are all of a sudden very keen to look at this sort of stuff. So as you're going through the case, the next thing to do is to actually start changing the patient that the registrar is seeing, and start saying, what if this patient was older? What if they were younger? What if their pain was a little bit different? If it was sharper, duller in their epigastrium, a little bit higher, a little bit lower, and asking them to try and think about how that might change their differential and their approach. And to get them to start thinking about why they're deciding what they're deciding about patients. It's a very powerful tool. The extension of that is to go through their letters from their consultants that are coming back to them and their pathology results. Ask them about why they've ordered that result, what they expected to gain from it, going back and opening the patient up and going through that. It's a very powerful tool for the exam. It's a very powerful tool for use appropriate pathology tests and prescribing for registrars. So again, this is designed just to be a taster for these topics, and it is worth having a look at this if you've got time in a little bit more detail. There's also a really good article in KFP in the AFP about this as well. Video consultations. So I've actually become more and more enthusiastic in the last couple of years about doing video consultations, and there's a couple of reasons for that. I read an article saying that it's actually probably the most effective teaching you can do. It's much more effective than actually sitting in person. And the other thing is it actually gives you the ability to combine the two previous things, where you actually can be doing the same sort of things that you would do if you were sitting in, but you can also stop the replay and do the random case analysis stuff. What if this person was older? Why were you thinking what you were thinking? What if that had the pain for longer or shorter? So it's a really important tool in that sort of way. It actually is good in terms of teaching consultation styles. So the registrars can actually see how the patients are reacting to them and what they're saying much more clearly than if you were to talk about it at the end of the consultation in a direct sit-in. So I've actually started doing a lot more of this. The problem with it is that no, I don't remember the article. As I said, I'm a GP and a supervisor. I'm not an academic, so I don't tend to remember the article names. But it was in AFP a couple of years ago, I think. So you can address the style of the consultation really well in this sort of format, and the ability to stop things and replay them is a really powerful tool in video consultations. The problem, of course, is that we all hate it. The registrars hate it, the patients don't particularly like it, and as supervisors we feel awkward about it as well. But if you can make yourself do it, I think it's a really worthwhile thing to do. I actually do have a little dedicated camera. I don't like using phones because I know if I was a patient I would be a little bit unhappy about the privacy aspect of that and where phones go and things being uploaded to cloud services and things. But I know a lot of people do use phones, but I don't. So getting back to the idea of you don't have to do all the work, and that this is about the registrars learning. I do ask the registrars to do presentations, and at the beginning of the term and before they actually take the job on, they know that they're going to have to do that. So we have regular practice meetings, and I ask the registrars to present topics on that. So it might be something that they're particularly interested in, or it might be something that you would like them to be particularly interested in. They're short presentations, they're 15 minutes. Most of the registrars do feel more comfortable using PowerPoints, but that's not important. the registrars actually don't mind it. It's usually stuff that they're going to have to study anyway, and it actually helps them formulate their ideas. And it's really great for the rest of the practice, because we all learn something. So the sorts of things, I mean, when the new pap smear regime came in, I asked the registrar to present to that. As the coding scheduling came in, I've asked the registrar to present some topics about that from the NPS advice and things. So it's a really great use of this, and it's a great opportunity for everyone then to discuss these things within the practice, and it's less work for you, which is important. So one-on-one small group tutorials. So we had a little bit of a chat about that, setting up the tutorials. But as I said, really important that you don't have to do all the work. So use everyone in your practice to do this. It's actually worthwhile to ask the registrars to present either to you or to other registrars within the practice. Again, it's about saving you some work, but it actually enhances the educational experience for the registrars if you do it that way around. It's better for them and it's better for you. At the end of it, so when I find that I do this, I find that the registrars will go to the guidelines as they do. They tend to be much better guidelineologists than I am, and they will present to me all the latest in the guidelines, and that's really good for me because I'm brought a little bit up to date. And then there's the value add that you can do at the end of that, saying, but this is how I would be applying these guidelines in the real world, and this is what it means to me. And then that chat that ensues in the end is the value add for the registrar, and that's really important. The other thing about the formal teaching sessions, as I said, they don't have to be in a formal environment. Nicole tells me that she has done interesting teaching sessions at the beach, watching whales, doing origami. So think a little bit laterally. Don't restrict yourself to being in your consulting room or in your lunchroom. If you can make the teaching more enjoyable for yourself, you're probably making it a lot more enjoyable for the registrar, and everyone's happier and learning more in that circumstance. Watch and do. So just, again, a lot of registrars these days will now coming out who haven't done a lot of clinical, sort of a lot of hands-on things. They sometimes actually haven't cut out something before. They may not have even done a lot of suturing. So it's a good idea to ask them about that early in the term, and where possible to actually watch them do a lot of these procedure things. And that's, again, it's important to try and cover early in the term. Near-miss analysis is a great learning opportunity for the whole practice, and particularly for our registrars. So getting back to that idea of culture and having a great culture in your practice. So setting that up in the meetings and letting the registrars see that everyone's participating in the near-miss analysis. So for those, I'm sure everyone probably knows about that, but so for those who may not have heard a lot about it, the idea of near-miss analysis is that if something could have potentially gone wrong, but actually hasn't catastrophically, it hasn't really gone wrong, it's a great opportunity to discuss that as a practice and to be trying to look at how to repair those and prevent those sorts of things and similar things in future. And I think it's a great teaching experience for the registrars to see the whole practice doing that. This gets back again to slides about, again, the clinical reasoning. Just getting mindful of the time. I might skip over this, but it's, again, there's another whole podcast on YouTube about this sort of, about clinical reasoning. The first one is describing heuristics. So that's about for the type 1 and thinking, for those who've heard about the think fast and think slow thing. And So the heuristics are just simple rules of thumb that allow you to look at something and go, yes, this is this, and no, that's not that, and explaining those to registrars and empowering them to use those heuristics and to realise that they are useful. But when they let you down, then to be doing the type 2 thinking and trying to work through things in a more methodical way. I might skip through the rest of that, actually. Nicole, is there anything that you particularly burningly want to say about that? No. So the Bayesian theory is about looking at pretest probability. It's about having an idea of what the clinical course of things are and seeking out things that don't fit. And when things don't fit, looking at other issues. Sorry, Nicole?
Actually, just going back to those heuristics and thinking about clinical reasoning and you know, if that 65-year-old man who walks in with chest pain, you know, our first thing, the most likely thing is our rule of thumb is a cardiac, and you know, if that 65-year-old man who walks in with chest pain, you know, our first thing, the most likely thing is our rule of thumb is a cardiac, but taking your learners on, you know, it could be anything else. If there's any serious disorders not to be missed or a safety netting. It's just registrars always tend to go to the most obvious things and throw away safety netting. It's just registrars always tend to go to the most obvious things and don't look beyond it.
Thanks, Nicole. I couldn't hear that, but thank you. I'm sure it was why. Yeah, so the comment was there encouraging registrars to slow down, and that's really important. And that gets to, you know, embracing the zebras and Hickdom's dictums. And I think that you know, Hickdom's dictum is that patients will have as many diagnoses as they damn well please, and as being the opposite of Occam's razor. And it's something we actually see commonly in general practice. And I think as we become experienced general practice, we're often become more alert to the idea that this patient may actually have two problems that are explaining the issue. And so encouraging registrars, it all gets down to encouraging registrars to be more curious, to think a little bit more broadly, registrars to be more curious, to think a little bit more broadly, and to safety net and look at the worst case scenario stuff. It's a whole topic in itself, but it's really important that we do it, and it gets back to the idea that I said before. Registrars are actually now really willing to embrace this stuff and look at it, and it's all because of their KFP exam. These are all important issues for the KFP exam and getting a good result. What do I mean with embrace the zebras? In general practice, you know, common things occur commonly, and so we always look for the common things. The problem is that all of the really, I tell the registrars that all of the really uncommon, rare things that patients that have got the really weirdest, rarest conditions that are lying in a big public hospital, tertiary hospital somewhere, have probably come through a general practice somewhere. So zebras actually turn up in general practices. We all see them. And one of the real skills in general practice is just being alert to the zebra that walks through. That's not actually a horse. Actually, I was just thinking. I hope you've heard the analogy that it's to do with the idea that if you hear hoof beats in coming down the street, it's much more likely to be a horse than a zebra. But just occasionally, it is a zebra. So another useful teaching tool is audits. So this is the medicine-wise. So some of them are pre-packaged, but it's actually a useful thing to do to sometimes ask the registrar as a teaching exercise to actually conduct an audit themselves, to either manually or using the software to go through and audit themselves, or you and them, and as a comparison in various things. So, and it might be how many allergies are recorded. It might be how many people with such and such a condition. It might be how many people with ischemic heart disease we have that aren't on a beta blocker. So there are other software tools that help it. The PenCat tool. I particularly like the Doctor's Control Panel. Has a little auditing feature in it that breaks things down much more conveniently per doctor. So I use that one in the practice, and it can audit we can audit all sorts of things. So I asked the registrars to do that and present it at the meetings, and that's a really valuable learning exercise. It's something that occurs in other disciplines. The surgical registrars and the medical registrars expect to do this all the time. So I think it's reasonable to expect our registrars to be doing it as well. This is, I guess, a little bit of an extension, a little bit of a push. Just one of the things I found with problematic registrars over the years is some quite difficult registrars. It's actually difficult to broach subjects with it. So I found it's very useful to have a system of feedback for the whole practice that just rotates around the practice, so that there is feedback in a formal manner, not just in the informal manner that we all do all the time, asking our reception staff and the nurses how the registrars are going. But having some formal feedback mechanisms so that when things get difficult, you can actually say, look, these are the sorts of things that we're having, these are the sorts of problems that we're having, and that is actually a great way of bringing up those difficult conversations. Building that into your practice and making it a normal part of your practice is a really useful thing to do for the practice as a whole, and is also a particularly useful thing to do for registrars. It takes a little bit of work to set up, but it can be life-saving when you have a particularly difficult registrar. Learning can happen anywhere, we've already discussed. Disaster files. So a lot of supervisors keep a list of all of their stuff-ups. It's very powerful for registrars to hear from the supervisors things that they've done wrong in the past. If you're game to do it, registrars love it. I often talk about my stuff-ups from my registrars, and sometimes I think they're sitting there going like, wondering why they're listening to anything I've said because I've done something so stupid in the past. But it's really useful for them to hear that we all make mistakes, and it's often about how we recover from them. And often, if you can explain to them the things that you've done wrong, it saves them from making the same mistakes. So a lot of supervisors actually just keep a list of all of their problems, and it shows that none of us expect to be perfect or are perfect, and it does indeed model that vulnerability, as Nicole said. So a little bit of talk about supervision in the 2 minutes that I've got left. So this is the 1 minute method. Feel free to Google it. The key thing that I find about this is the get a commitment. So make sure the registrars know that that it's not okay to ring you up and say, give you a 6-year medical student presentation on a patient and ask you and just say and leave it at the end and say, what do you think? Because really they're just asking you to see the patient for them. So so it's really important for them to give a commitment about what they think's going on and what their plan is, and then probe for evidence, reinforce what's done well, and give some guidance about that. It's just a way. It's just a simple method to try and stop you as a supervisor from doing the natural thing that we all want to do, is just jumping in and telling them what to do. So it's that asking first dictum, and the things I remember most about this is the get a commitment and probing for evidence, and then trying to work through what they said, and trying to give them some positive reinforcements. The second last part about it is the teacher general principles. So, you know, patients who present like this, in general, these are the sorts of things we need to look at. I'm going to skip registrars and difficulty because I'm running out of time. And there's another podcast, another webinar on this that's available on YouTube. The only thing I will say about that is with registrars in difficulty, if you really feel like you're struggling with the registrar and things are starting to break down, the most important thing I can say is to get help early. So ring the medical educator, ring the SLO in your area before things get too bad. It doesn't hurt just to have a little brief chat, get some guidance, let them know where things are going, and they may actually not need to do anything. But if you can break the circuits of things going off the rails early, that is really helpful. One of the problems of GPs is we have as GPs is we feel like we should be able to solve everything, and it's just not true. So and having that objective standpoint is really important. So this is getting to this is just about the idea of being curious about your registrars and encouraging them to be curious about their patients. This is a commonly used feedback format. So it's divided into to keep doing, do more, stop doing, and try this. The way I actually remember this is things that you're doing well, things that you need to do more of, things that you need to do less of, and the stretch. So that's how I remember it, rather than these things. So good, then sort of more, less, and what things can you, the stretch is what things could you do with this patient with a patient like this that would help you in future, what additional skills you could get, what if you said this to the patient. It's a little bit back to what we're talking about with the clinical reasoning, the video consultations. As I said, I've got a very simple supervisor kind of mindset rather than a medical educator mindset, so that's how I remember that. Okay, sorry to rush those a little bit. So just some couple of key things that I'd really like people to take away from tonight. So importantly, the separating the industrial side of things, the employment. So for those of you who are supervisors and also practice owners, so separating that as much as possible is really key and really important. So separating that in time, so all of that stuff is signed up and done and sealed and delivered before the registrar walks into the practice. Also, as much as possible, separating that in person. So having the practice manager as the first port of call for the registrar if they've got any concerns about money, conditions, pay. Even though the practice manager is just going to go straight to you and ask you about it, it's much better if those discussions go through the practice manager, just as a way of psychologically separating and not contaminating the relationship that you have as a registrar, as a teaching registrar. Make sure contracts are signed. The registrar is in charge of their own learning. It's not you. You're there to help. You're there to oversee. You're there to provide supervision. You are there to make sure it actually happens. It's really important as a supervisor that you make sure that the teaching actually happens and the supervision happens. But you do not have to do it all. That's really important. Do everything you can to make it enjoyable. I think that's so important. It's so important for the registrar, and it's so important for you to not get burnt out either as a doctor or as a supervisor. Think laterally and be prepared to learn from your registrars. But most of all, have fun and enjoy it. So any questions or burning comments?
Oh, thank you, Bruce. Can you actually hear me now? No. Oh, yes. Bruce, can you actually hear me now?
Yes.
No. Oh, yes.
Oh, I can't hear you.
I guess the one thing that I find now as a new practice owner, separating the industrial from the teaching and preserving my relationship with my practice owner, separating the industrial from the teaching and preserving my relationship with my registrar through my communication mentorship is probably the gold nugget out of everything for me. It's really important. Lovely wants to know how this is different to a supervisor workshop. Lovely wants to know how this is different to a supervisor workshop.
This is probably about 5 supervisor workshops in one. So it's probably 5 full-day supervisor workshops in one. So really try to just skate over and a lot of these things are headlines and just take home. This is the Reader's Digest versions to supervisor workshops. The other thing that I guess I didn't mention is getting to know the rules and requirements of your particular RTO. What they need from you. That's really important. Getting back to so most of the all of the RTOs require you to do supervisor upskilling. So most of the RTOs will accept these webinars as part of that. So if you contact their RTO about having that accredited, for my RTO, it's a matter of writing into the RTO and saying what things you've learned from it and what things you'll do different. 3 things you've learned and 1 thing you'll do different. But different RTOs will have a different system, and they'll accept that for watching back the videos on YouTube as well. So contact your RTOs, and if they're not accepting these webinars as part of their supervision campaign, and most of them are because it suits them, because it's something that they don't have to do. Ask them if they could.
Thank you so much, Bruce, for an excellent webinar, some great teaching tips, and also thanks, Nicole, for sharing some of your great tips and experiences via the chat box. It's been a fantastic webinar. Sorry about starting a little bit late, everyone. We would really love your feedback. Marissa has already sent out an evaluation